Okay, and we are live. Hello, web shadowers. Thank you all for joining our session today. Today we have the pleasure of hosting Dr. Masood, who will be teaching us about pediatric cardiology. As always, please remember that the Google form will be posted in the chat box and in the description of this video at the end of the session. With that being said, Dr. Masood, you can get started whenever you're ready.
Hi, everyone. Welcome. Really excited about today's session. So again, we'll be talking about murmurs today. So a little background about myself. So I'm a pediatric cardiology fellow, currently in training right now. So by no means am I an expert in this field, but do have plenty of experience with it. So I'm going to go ahead and get started. A few disclaimers here. So again, just want to remind everyone, I'm not providing any medical advice. All opinions that I am talking about today are my own. They don't reflect where I work, and I'm not going to be sharing any protected patient health information. All right, so for today, we'll start by talking about different types of murmurs, and then we'll move on to some cases here. And then I want to remind everyone that we'll have a lot of audio and video clips here, so it should be a little more interactive. If you can, try to have your volume up for some of the audio clips because the quality is not like super perfect, but I want to go ahead and get started. All right, so before we jump in, I wanted to quickly just show this diagram here. So this is a complex looking diagram. Again, we're not going to go through all of it in full detail, but it is kind of helpful to know that the cardiac cycle has different phases to it. And so we have, again, we'll go into this in a little more detail in a second, but we have systole and diastole are kind of the two main phases that we're going to talk about. And you'll notice that at the bottom here, we have our heart sounds. So a tracing of our heart sounds down here. We have our electrical activity, which is kind of a recap from last time I gave a lecture on this forum. And then the pressure tracings up here, which talk about the ejection and relaxation of the ventricles. So again, we're not going to get into too much detail about this, but I think it's helpful to kind of think about where the sounds line up with the cardiac cycle. All right, so we'll start by going through the normal cardiac cycle. So again, we have two main sides of the heart. We have the right side and the left side, and then we have four chambers. We have two atria, so the top chambers are the atrium, so right and left atrium, and then right and left ventricle are the bottom chambers. So normally deoxygenated blood, so these blue arrows right here, we'll call that blue blood. This is blood that has already been to the body, it's done its job, it's given nutrients and oxygen to the tissues, and now it's coming back to the heart and is ready to pick up some more oxygen. So we're going to call this deoxygenated blood, because it is not oxygen rich. So we have two main sources of venous return to the heart, and so we have our SVC, also known as the superior vena cava, and we have the inferior vena cava. These both attach to the right atrium. From the right atrium, they then go through this valve, which is called the tricuspid valve, into the right ventricle. So again, remember that the ventricle is the bottom chamber. And this valve here, so the idea with these valves is that they are designed to block flow from going backwards. And so if they work perfectly normally, blood should come in, and then when this bottom chamber squeezes, this valve should close so that blood is not going to go back into the atrium, but instead should go forward. And so then after the right ventricle, it'll go into the pulmonary arteries. So we'll cross this valve right here, which is called the pulmonary valve. Again, same idea, one-way street to get into the pulmonary artery. You'll sometimes hear me refer to this as a PA or MPA, MPA meaning main pulmonary artery. And then once we get there, we go to our branch pulmonary artery, so we go out to each side here. And then once it gets out the pulmonary artery, it goes to the lungs and picks up oxygen and it gets rid of carbon dioxide. So it'll then come back from the lungs as red blood, so now it's full of oxygen. That blood now comes back to the pulmonary veins, to the left atrium. Then from the left atrium, it'll cross into the left ventricle, as we can see here. And the valve that it crosses to get from the atrium to the left ventricle is called the mitral valve. Then from the left ventricle, it'll eject, it'll go out the aortic valve and up the aorta. So that's this big red arrow here. And the aorta gives rise to all the arteries in the body. And so that blood will go up to the brain, it'll go everywhere, to the arms, legs, to the internal organs, liver, kidneys, etc. So that's a normal flow of blood in the heart. And this is important because when we think about the murmurs, they depend on different flows of blood and the sort of closing and opening of the valves. All right, so like I said before, there's two main parts of the cardiac cycle. So we have diastole and systole. So the easiest way to think about this is that diastole is when the heart is filling, and systole is when the heart is ejecting. So basically the heart is squeezing during systole and the heart is relaxing during diastole. So what does that mean for the valves themselves? So if you think about it, if my heart is filling, when I say the heart, I mostly mean the ventricles is kind of the main idea. So as the ventricles are filling, these two valves, right, the tricuspid and the mitral valve, those valves should be open. So as the blood is coming in from the atria to the ventricles, you want that blood to fill in. So you want an open valve on both sides. So during diastole, we call these the atrioventricular valves. It's just a way of saying the valve between the atria and the ventricle. So I'll say atrioventricular valve. Sometimes we hear me call it AV valve. They should be open during diastole. Your other valves, so the valves that go to the aorta and the pulmonary artery, these are also called semilunar valves because of the way that they are shaped. But the semilunar valves should be closed during diastole. So as your heart is filling, you don't want to be ejecting any blood out, so you're going to block off these outflows here. Then when the heart is ready to squeeze, again, you don't want blood going back into the atria because that's not ideal, right? That's kind of a waste of energy. So these valves should close, and so your AV valves, so your tricuspid and mitral valves will close, and your aortic valves will open. So that's a really important thing to keep in mind, that when you think about heart sounds, this is where a lot of our stuff is derived from. So in a normal cardiac cycle, we have two main heart sounds. You've probably heard of lub-dub as kind of the colloquial way of saying it. The reason why we think that is there's, again, two main events. So the first heart sound, so the lub, is when these AV valves close. So when the tricuspid and mitral valve close, that's the first heart sound. Then remember that as these are closed, the heart is ejecting. So the pulmonary artery and the aorta are both squeezing blood out. As soon as those are done, these valves are going to shut close. So your aortic and pulmonary valve will shut close, and that'll create your second heart sound. So the first heart sound is caused by closure of the AV valves, right here and here. And the second heart sound is caused by closure of your semilunar valves, so your pulmonary valve and aortic valve. All right, so again, a common way that we like to think about murmurs is this little sort of diagram here. And so you'll think about our first heart sound and second heart sound. We call this S1 and S2, just a fancy way of saying the first heart sound and second heart sound. Again, keep in mind that diastole happens when the heart is filling, the AV valves close, the heart ejects during systole, and then when it's done ejecting, your aortic and pulmonary valve close to create the second heart sound, and then diastole starts again. All right, and I have an example here of a normal heart sound. Go ahead and play this. So I'll play it a few times. I want everyone to try to remember what that sounds like. One of the keys with listening to murmurs and heart sounds is that when you get out there and start listening to enough of these, you kind of start building up a mental library. So once you hear enough of them, you kind of recognize what's normal and what's abnormal. So I'm going to keep playing this several times just to kind of get an idea of what it sounds like, what a normal heart sounds like. We'll do it one more time. All right, here's another example of a way to look at that first diagram, kind of broken down a little bit. So again, we have our first heart sound, we have our ejection, then we have our second heart sound, and then we have diastole. And then we have our first heart sound and ejection. Okay. Now this next slide, we'll go ahead and take a look at an echocardiogram. I think I'm frozen here. Give me 1 second. again, so here's an echocardiogram. So this is called an apical 4-chamber view. So if you recall from those diagrams, we have 4 chambers here, right? So this is where my pointer is. This is the right side of the heart, and this is the left side of the heart. So if you imagine the patient is kind of like staring at you, is looking at you, and this is the heart sitting in their body. So even though this is on the right side of the screen, it's actually the left side of the heart. So we have 4 chambers: right atrium, right ventricle, left atrium, left ventricle. All right. Now here with echocardiograms, what we can do is we can place color over these images. And so again, the idea here is that with color, we're able to see the general flow of blood. So it's not too important to memorize this, but the idea is that on any ultrasound, for the most part, when you have 2 colors, one color should be towards your ultrasound probe, the other color is away. So here we have red is towards our ultrasound probe and blue is away from it. So what you're looking at is our left atrium is squeezing and there's this big surge of red as it's coming down into the left ventricle. And in between there, you can see this little rim, this kind of thin white line, that's your mitral valve that's blocking the blood from going backwards. So this is kind of a normal appearing flow of blood from the left atrium into the left ventricle as seen by echocardiography. Sophia, can you just confirm that these videos are coming out okay? It's looking pretty laggy on my end.
Yeah, they're looking frozen on my end.
Okay. Well, that's unfortunate. Well, we shall move on. All right, so here is, again, going back to that diagram that we saw earlier on. A lot of stuff going on here, but the main things to keep in mind are follow just the blue tracing right here and this gray thing down here. So again, as we're ejecting, we're creating this sort of increased pressure. So this blue arc is a systolic phase, so there's ejection here. And systole is kind of like defined by the gap between this first heart sound and second heart sound. So I think of, when this first heart sound starts is when the ejection is starting, and when the second heart sound is heard, that should be the end of ejection. So it's kind of a nice way to just lay it all out together. All right, before we move on, are there any questions about that part? Again, we're flying through some cardiac physiology pretty quickly, so I'm going to pause here to see if there are any questions. All right, great. Looks like no questions yet, so we will go ahead and keep moving. All right, so a couple of things about murmurs. We have ways that we grade them. And so this is really important. One habit to get into is whenever you talk about a murmur is that you always describe at least the gradation of it. So this is our grading scale that's the common convention. So there's 6 levels. So 1 is barely audible, 2 is pretty well heard. Sometimes people say it's kind of like the same volume as a breath sound. If you hear the lungs breathing, it should be similar. I don't really like that because in kids especially, like they're sometimes crying or, they breathe heavily. You may not be able to make that comparison. Grade 3 means it's very easily heard. Grade 4, the difference between 3 and 4 is that if you put your hand on the chest, you actually will feel some of the flow of blood underneath. Grade 5, if you hold the stethoscope right over the chest, so a few centimeters off, you actually can hear the murmur even from being off the chest. And then grade 6, these are pretty interesting. You actually can hear this without even using a stethoscope. I've had patients where you walk into the exam room and you can hear their murmur without even, like you're 5-6 feet away from them, you can hear it. So that's kind of our general grading scale here. Someone once told me, like, kind of as a joke, the way to remember these are, Grade 3 is kind of like the medical student murmur. So it's the most easily heard. It's very loud, so a medical student can hear it. Grade 2 is like your resident murmur. So a little bit less obvious, but more experienced person can hear it. And then grade 1 is like your attending level murmur. Again, doesn't mean that anyone can't hear a grade 1, but it's kind of just a learning technique that one of my attendings have came up with. All right. So I wanted to pause and actually ask, and I wanted to take people's input on this, because I think it's kind of an interesting topic, is this question of, are murmurs dangerous? Because this comes up all the time. Parents ask this all the time, patients ask it all the time, and it came up during our last web shadowers talk as well. So I wanted to hear if someone from the audience had some thoughts on this. Are murmurs dangerous or not? And if so, why? All right, I'm seeing here a couple things. There is one question, which I will get back to in a second. Thanks so much. So someone said not always, but yes. Someone said they can be if they get worse. Someone said depends on the situation. All right. Depends on the severity. All right, these are all great thoughts. So before I answer that, I want to ask another question is, what even is a murmur? All right. Abnormal heart sounds, exactly. So I think that's really important to keep in mind. That's all it really is. And a murmur is just an abnormal heart sound, and that's it. So when we hear murmurs, all we're getting from that is that there's some abnormal sound of the heart itself. It doesn't always mean that there's actually something dangerous or something wrong with the heart. It just depends on the flow and the valves. That's pretty much it. So I'm seeing a lot of people say it depends on situation, depends on severity. This is true. So murmurs themselves are not dangerous, but murmurs can tell you if something dangerous is happening. Right, I'm gonna say that one more time because I think that's really important. Murmurs themselves are not dangerous, but they can tell you if something dangerous is happening. Okay? So here's kind of a long list of things. It's very wordy, so I apologize for that. But in pediatrics, most murmurs are actually normal. But we do have a list of a few things that we look at to make us concerned that this murmur actually could mean there's something more concerning happening underneath. So for example, if you have a loud murmur, it's grade 3 or higher. If it's a harsh sound. If it's holosystolic, which means that it's happening throughout the entire systolic phase, as opposed to just halfway through or like a quarter of the way through. Anything diastolic in pediatrics, to me, is concerning. If the murmur gets worse when you stand up, the reason why this is the case is because if you have hypertrophic cardiomyopathy, those murmurs can get worse as you stand up. If you can hear the murmur in several parts of the chest, so radiation to other areas here, so for example, if you listen at the left sternal border, you can hear it, and let's say you hear it at the apex or the back, that's concerning as opposed to if you only heard it at one spot. If the patient has other symptoms like chest pain, fatigue, palpitation, syncope, that also makes me more concerned, and then any vital sign issues. So those are kind of the main things I think about with what makes a murmur concerning or not. All right, so I want to kind of just get caught up with some questions here. So someone said, what does a cardiac stress test show? So stress testing, what we do for that is that we take a patient, we put them on a treadmill or a bike, we hook them up to an EKG machine, and sometimes we put them on a breathing tube that can measure the carbon dioxide and oxygen levels. And what we do is that we see what happens to their heart when they're working at a really fast rate. So if you think about it, sometimes your heart muscle may be completely normal when it's doing the bare minimum. But as soon as you have to increase the amount of work that your heart is doing, then we start to uncover that maybe there is actually some like silent disease or subtle issues. And so that's the idea of doing a stress test. Sometimes we will do echoes as well with the stress test. So we'll have kids that, we'll get them on the bike, get them up to peak exercise, and then we'll put the echo probe on their chest while they're at peak exercise to take a look at how their heart looks when it's working as hard as it can. So that's the idea of a stress test. Sometimes murmurs will happen regardless during a stress test because as you're pumping really fast and really hard, you're going to have increased flow. And as that flow increases, it might just sound a little bit louder as it's going through the heart, and you might hear a little bit of a murmur. I think I saw someone also mention flow turbulence. That definitely is a component as well. So turbulent flow can make the heart sounds a little more abnormal. Alrighty, another question here. Are heart murmurs often misdiagnosed? So that's an interesting question. Do I think heart murmurs can be missed? That can happen. So people can miss heart murmurs, like someone has a really soft murmur, like grade 1 or grade 2. In kids, especially if their hearts are beating really fast, sometimes it's hard to hear because it's going so quickly that it takes a lot of experience to actually get good at hearing those murmurs. So they can be missed. In terms of misdiagnosed, usually not, partly because we have echocardiography. So echocardiograms are great because we can get really great images of the heart, and we pretty much can make all the diagnoses, at least for murmurs, with an echo. So I don't think I've seen misdiagnosis happening too often. How often do I see concerning murmurs? So this is an excellent question. And I think part of the answer to that is depending on who you ask. So for me personally, I work in pediatric cardiology. So a lot of the patients I see, there's a bias towards kids who have heart problems already. So I hear murmurs that are concerning almost every single day. Now, the question of like how many clinic patients referrals do I get for murmurs that are concerning? In the clinic itself, most of those kids have normal murmurs, so usually pretty unremarkable. One more really important point I want to make here is that for anyone who's going to primary care, it's extremely important to get good at hearing these murmurs. So as a cardiologist, the only way I ever see these kids is if the pediatrician refers them to me. So it's extremely important that the pediatrician is able to listen and hear this stuff. And I've had the pleasure of working with some really excellent pediatricians who are good at hearing murmurs, and that's how they pick this stuff up. All right, there's a question. Does anxiety increase the risk of having dangerous murmurs? So anxiety would not increase the risk of having a dangerous murmur. In theory, there are certain lesions, for example, hypertrophic cardiomyopathy. When the heart is beating faster, you can actually have more problems getting the blood out of the heart, so you can have obstruction to flow. So I guess in theory, if you do have a fast heart rate, it might be more obvious to hear that murmur. So that's probably how I would connect those two things. All right, and then I just posted a link here at the bottom. So this is a website called Peds in Review. It's run by the American Academy of Pediatrics. It has a really good article on this idea of what is a dangerous murmur and what's a innocent murmur. And then one more thing they put in the article, I actually don't really use this in my personal practice, but for someone, if you're curious, the 7 S's of innocent murmurs. So any of these things should help reassure you that the murmur you're hearing is probably something normal. So again, systolic murmurs are usually not a problem. If it's a short murmur as opposed to holosystolic, like we talked about last time, holosystolic being the entire cycle. If it's a small area, meaning that you hear it in one part of the chest and not others. If it's a low amplitude. So here's the other thing we didn't really talk about, but the quality and characteristic of the murmur. So, you'll hear the difference of people saying it was a harsh quality, like the actual sound just sounded very harsh, versus you kind of have like these lighter, more, people use the word musical sounding murmurs. And then single, meaning that if you have other sounds, so clicks or gallops, that could be concerning. So a click is something you hear when you have a stenotic valve, so a valve that's narrow. Sometimes as it's opening, it creates a click, and so that can be concerning. A gallop is a sound you hear when the heart is actually not beating well. If you have heart failure or congestive heart failure, you can sometimes hear a gallop, so those are concerning too. And then sensitive, meaning that it changes with position, is usually a good sign for the most part, although there are some exceptions to that. Okay, let's get caught up on some questions here because there are a few queued up. Oh, actually, no, we are all caught up here, if you'd like. Great. All right, so let's go ahead and move on and talk about some cases. All right, so I kind of built these based off a typical clinic day that I would have. So our first kiddo, this is a 4-week-old baby. She's referred to the cardiology because her pediatrician heard a murmur. So before we move on, what questions do people have about this story? So a kid like this comes into your clinic, there's certain pieces of information that you want to know. Okay, so I'm seeing, when did this start? So the pediatrician heard it a week ago at a routine well child check. So the baby just came in for a regular visit, for a healthy visit, and then we heard this. The pediatrician heard the murmur and then sent the baby here to cardiology today. Medical history. So the baby's 4 weeks old. So what kind of medical history, when you say medical history, what does that mean exactly? So, okay, great. Someone else already asked the question that I was going to get at, which is, was it a normal birth? So in the babies, the birth history is going to be the huge majority of the medical history. Extremely important to get a good birth history. So people are asking, I'm seeing in the chat, was it a normal birth? Was there any complications? So the baby was born full term, was born by C-section because mom had her previous C-section, and so it was a repeat. The APGARs were 9 and 9. The baby did not stay in the NICU. The baby passed her congenital heart disease screen, which is done at the newborn nursery. Normal hearing test. She got her vaccine, Hep B, vitamin K, all normal. All right, any cardiac issues in the family? No issues at all. Everyone's healthy, except grandma had a heart attack when she was 70. Was the baby full term? Yes, full term baby. Okay, great. So I don't think anyone asked this yet, but this question of feeding, really important. So earlier in this session, somebody had asked about a stress test, right? And so the idea with a stress test is that when someone is resting and their heart is not really working that hard, sometimes you don't detect any issues because the heart is not being stressed out. However, when you start stressing the heart and you exercise that person, you'll start to realize like this heart actually really struggles when it comes to having to increase its, heart rate and stroke volume and contractility. And so in babies, we can't really do exercise testing. And so one of the most sensitive ways, and so when I say sensitive, it means it's good at detecting. One way of asking this is how the baby does with feeding. So for little babies, feeding is pretty much exercise for them. It's quite a bit of work. It uses a lot of energy. They have to coordinate their breathing, and so they're not going to be breathing normally either. And so when I hear that a baby is struggling with feeding, it almost, to me, is like, that's kind of like a stress test in a way. That to me is like, this baby can't, quote unquote, exercise. I'm doing air quotes. You can't see me because I don't have my camera on, but that idea of kind of like exercise for the baby. So this baby is struggling a little bit with feeds here. No family history, which you guys asked about. And again, full term C-section. APGARs were normal. So normal APGAR is 10. 10 is a perfect APGAR. 9 and 9 are also great. Did not spend any time in NICU, normal birth weight. And then the baby does breastfeed about every 3 to 4 hours and does about 15 to 20 minutes worth. There's a question in the chat about the mother's health during pregnancy. Excellent question. So the mom had a completely normal pregnancy. She had ultrasounds that were normal. All of her blood work was normal as well. All right. So before we move on, one other important thing that I want to point out here is that growth charts in pediatrics are, first of all, before we go on, I just want to point out how cute is this baby. All right. So growth charts are extremely important. And so this is the way that we measure height and length in babies. And the idea behind this is that these percentiles, so you can see these lines here, are kind of like a statistical distribution of the normal population. So what that means is that 5 to 95% of the population will fit within this range of weights here. And so this is a good way to keep track of, are babies smaller than age? Are they smaller than they should be for their age? Are they growing faster than they should be? This is also helpful because you'll notice that when you graph this out over time, sometimes the baby starts at like the 20th percentile, and then you see them a week or a month later, now they're the 10th percentile, and then you're seeing that they're kind of, we say, falling off the curve. Is another way to track abnormal weight gain. So this is important in the cardiology world because, like I said, feeding is a really important thing for babies. It's pretty much the most active thing they do early on in life. So if they're having a hard time getting enough calories in because their heart is not able to work hard enough for them to allow them to feed, then they actually don't gain weight very well. The other thing is if their heart is struggling for some reason, that can lead to increased caloric needs. And so these babies actually need to take more than usual, but then they can't because their heart doesn't work well. And so they end up not gaining weight very well. And so we often use this growth chart as a really helpful tool. All right, someone asked, what is an APGAR? All right, so APGARs are a tool that was used to sort of grade when a baby is born, how sick are they, and kind of gives you an idea of how likely are they to have certain neurological injury or have issues with or complications from the birth, essentially, is kind of the short answer. So the APGAR is actually mnemonic. It stands for A is for the appearance of the baby. So we look at the skin color. You know, are they pink or are they blue? The P is for pulse. And so we generally break it down as, is there absent pulses or do they have a normal heart rate? G is for grimace. And so this is a general sort of like agitation. So if the baby's agitated, that's actually a normal sign. Like as you touch the baby and try to do things to them, they should have a normal sort of agitated response. But if they're completely lifeless and not responding to you, that's concerning. The A is for activity. This is just general, how much they're moving their arms and legs and things like that. And then the R is for respiration. So usually we'll say if the baby's crying, that's like the best sign of a respiration. Sometimes you have babies who are just breathing slowly or if they're not breathing at all. So there's numbers assigned to each letter, and we use that to then figure out an APGAR score. Good question. All right, so we're here examining the baby. These are the vital signs. So we have a normal temperature. This heart rate is fast. Now I want to just point out, for a heart rate of 160, for most people, you look at this number and you're like, wow, that is super fast. It's an important point to note that heart rate is very dependent on age. So the smaller you are, generally the faster your heart is going to be. As you get older, our hearts tend to slow down overall. So little babies, they can have heart rates of 130, 140, you know, and that's not concerning. As you become an older kid or teenager, you might be like upper limit of 110, 120. And then for adults, normal is 60 to 100. And part of the reason with that is that babies' hearts are smaller and they don't squeeze as well. And so to make up for it, they have to beat faster and beat more often to maintain normal cardiac output. Now, I will say a rate of 160 for a 4-week-old baby is a little on the faster side. So I would be a little concerned with this number. The respiratory rate is also pretty fast. So I'd like to see it, you know, less than 35 or 30. So we're a little faster here. Oxygen saturation, so this is a normal number, 99%. Generally above 94 or above 92, kind of depending on who you ask, is a normal number. And then blood pressure, you know, it's hard to get in a little baby sometimes because they just wiggle and move so much. And so we often aren't able to get a good blood pressure. All right, So let's go ahead and listen to this heart sound, and I'm going to play it several times because I don't think the audio quality is that great, but I want people to try their best to describe what they hear. So as I'm playing, go ahead and type in the chat what you're hearing. A good description of the murmur is what I'm looking for. So here we go. All right, let's do that again. All right, so I like what I'm seeing here. Some people are saying it's heavy, it's a dense sound, it's very fast and muffled. All right, these are awesome. I'm liking what I'm seeing here. Sounds strained. S1 is harsh. Sounds like it's dragging. I think one of my favorite things in this list here that I'm seeing is there's no lub-dub sound. And that's really important because that's actually going to be really helpful in figuring out what kind of issue this is. All right, so I think everyone can agree that this is not a normal sound. Okay, so before I give away the answer here, one test that we do that's really helpful is an echocardiogram. Now, I'm showing them because I think it's interesting to look at, but in reality, when you become a physician or an NP or a nurse or whoever, or a PA, whatever it may be, it's really important to know that a good clinical exam gets you most of the answer. And so, again, I don't want to give away the answer yet, but just based off the age, the way the murmur sounds and the story, there's enough information here to actually tell you what the diagnosis is in this patient. But I do think it's interesting to look at the echoes, and so I'll go ahead and pull up the echo image. Oh, sorry, before we do that, this kind of going back to the diagram here. So like I said earlier on, we tend to look at it in this sort of fashion. So we have S1, and then you can ignore the fact that it's written as A2, P2. Basically, these together make up S2. And so this little black grid in the middle is just showing that you have this continuous sound throughout the cycle. And so this is called a holosystolic murmur. So I think when I had commented, someone said there's no lub-dub sound. The reason why you don't hear lub-dub is because this murmur is so loud and it's happening throughout the entire systolic phase. Hence the word holosystolic. Okay, great. So let's go ahead and take a look at some images here, and I'm going to see if I can try to optimize for video. Okay, here we go. All right, so I think it's still a little laggy here, but I wanted to open up the chat again. What do you all notice about this heart? There's something very subtle that's abnormal, kind of in the middle of the heart. All right, I'm really sorry these videos are not working. I was really excited about this, but it's all good. Okay, so while I'm waiting for some comments here, looks like there's a question. Could it be improper valve closure or a patent ductus arteriosus? Yes, it could. That's great. We didn't even talk about what a patent ductus arteriosus is. So for a quick sidebar, a ductus arteriosus is a normal structure that all people have in utero. So every fetus has a ductus arteriosus. Sometimes these things will persist even after the baby's born. So normally it closes in the first couple of days of life. Sometimes it lasts for weeks, and it can actually cause a murmur because there's a lot of flow going through this area. So the sound for a ductus arteriosus murmur is actually going to be systolic and a diastolic. So we actually call that a continuous murmur. It's going to be through both cycles. And the reason why is that there's going to be flow through your duct during systole and during diastole. So that's a good answer because we're kind of there, right? This is a systolic murmur, but we don't have the diastolic component yet. All right, so I'm seeing break between the atrias. Systolic valves are not in sync. So again, I'm not sure if the video is even playing or if it's frozen.
It's frozen right now.
Frozen, okay. All right, so I think the break between atria is close because there's actually a break somewhere else, and it's very subtle, like I said. But if you notice that this ventricular septum kind of comes up here, and then there's this little gap, this little black area right here, right? See that? Really subtle. Again, maybe it's not the highest quality image, so maybe it's a little bit hard to see, but take my word for it. There is a little gap right here. And so again, this is the ventricular septum, and we have a tiny, well, it looks like a tiny hole in that area. Now, let's go ahead and, oh, now it's blank. Okay, cool. All right, so again, I think you can kind of see a little bit better now with the image moving, is that there's like this little gap right here at the end of the septum where it should be connecting to the other end. And so what this is called a ventricular septal defect. So again, the ventricular septum, and there is a defect in the actual septum itself, so it's not connecting and closing all the way. And so there's communication between the right ventricle and the left ventricle. So is flow changing between the ventricles? That is a good question because it's kind of a complicated answer, and it trips up a lot of people, even like residents and fellows still get tripped up on this. Technically, yes, but also not really. And again, it's kind of a complicated answer, so I'm actually going to skip past it unless we want to get back to it at the end. It is kind of an interesting idea, but I think a little bit beyond the scope of what we're talking about today. But in general, yes, there will be flow from the left side towards the right side. So this will be what's called a left to right shunt. And this murmur is usually a harsh holosystolic murmur. So let's look at it now with color, or you know what, I'm going to skip past this because I think it's a little laggy. But with color, you actually can see the flow crossing over the septum and getting to the other side. Actually, I think it's working now. Yeah, so I've slowed down the image here a little bit. You can see that there's a little bit of that red flow on the right side that tells you that blood is coming towards the probe, right? Okay. So let's go ahead and switch back to non-video sharing here. Alrighty, so again, here's a diagram of what we're looking at. So this is a ventricular septal defect, like I mentioned before, so that oxygen-rich blood gets ejected and it can go over to the right side and it goes out the pulmonary artery. The quick answer to that question about does it kind of go between the ventricles? So the majority of the flow is going to happen when this ventricle is squeezing. So as the LV is squeezing, the RV is also squeezing, right? Because both ventricles should contract at the same time. So what happens is that technically this blood does go through the right ventricle, but the right ventricle is really contracted. And so the right ventricle doesn't really feel or get exposed to the blood. The blood kind of sneaks past the RV, and this diagram actually shows that quite well. it kind of just goes right through it real quickly and then gets up to the pulmonary artery. So it goes from the left ventricle to the right ventricle to the pulmonary artery. And that can cause a holosystolic murmur. All right, so for this child, what we're going to do is we're going to start some diuretics, and then we'll follow them up in a couple weeks. All right, so our next patient, this is now a 2-month-old who comes into our clinic for follow-up. This patient has hypoplastic left heart syndrome. They had a complex surgery called the Norwood procedure, and they had a sono shunt that was placed. They're on these medications, furosemide, digoxin, some vitamin D. The baby's doing well overall, they're feeding well, gaining weight, and they just came in for a routine follow-up visit. So I'm just seeing some questions here in the chat. Let me go ahead and let's take a step back because, sorry, I'm just seeing those now. There are some questions about the VSD. And let's see. So what is the heart rate for regular babies compared to babies with VSD? That is an excellent question. Babies with VSD should have fast heart rates. Part of the reason why is that if you think about this extra blood, so when the LV is ejecting, it's going to push some blood out to the aorta, and it's going to push some back to the pulmonary artery. Now, if you think about it, when it goes to the pulmonary artery, where does that blood have to come back? Where does it end up coming back? If you follow this path out here, it comes right back to the left side. So this left heart is now actually dealing with extra volume. And so what can happen is you can actually stretch out the ventricle and the baby can actually be in heart failure because the ventricle is now being overwhelmed and it can't handle all the extra volume. And so they can have really fast heart rates because they're trying to make normal cardiac output happen. So that definitely can be one of the big signs that the baby has a VSD. Will the baby require surgery? So it depends on the type of VSD. For the most part, the large majority is yes, kids will need surgery to fix a VSD. Sometimes if you have a VSD that's lower down, like in the muscle area, so we call that a muscular VSD, sometimes those close over time because the muscle just kind of grows and it just closes off. But there are VSDs that are higher up that are not really in the muscular portion of the septum, and those tend to be, those will usually need surgery. So is the baby losing quite a bit of oxygenated blood over time? So technically, no, they're not really losing blood, but if it's really severe, if that ventricle is struggling, what can happen is they're not going to eject as much blood out of the aorta. The other important concept is that the relative resistance, so the pulmonary vascular resistance compared to the systemic vascular resistance. So basically the idea is that resistance is a function of several factors, but one of them is the size of the vessels and the caliber. And again, that's getting into probably more stuff than we need to for this lecture today. But because the pulmonary vascular resistance is lower than the the systemic vascular resistance, what can happen is you get excessive blood that goes to the lungs because it likes the lower vascular resistance. And so in theory, if you're ejecting all that blood back to the lungs, you're not really going to eject it to the body. And so these kids sometimes can have issues where they're not sending enough blood to their organs from a VSD. Someone asked, would the VSD not have been picked up on congenital heart screens? Good question. So the way that we do congenital heart screens, there's a couple ways. So every baby, at least in the state of California where I practice, in our newborn nursery, we do a congenital heart screen, which the way we do it is that we take a pulse ox, we put it on the the right hand, and then any other limb, either left hand, left foot, or right foot. The reason behind that is if you have a really, really severe form of congenital heart disease, usually you'll need your ductus arteriosus to continue to send blood to your body. And the way that we can detect that is your right hand is all going to be before the duct, we call it preductal. The rest of your body should be after the duct. So if there's a significant issue, sometimes you'll have a difference in the saturation. So for example, a kid might have a saturation of 99% in the right hand, and have it be like 90% in the right foot, that would be concerning that there's some sort of congenital heart issue. And so that's why we do the screen on every baby. If we see that the screen is positive, then we'll go and get an echo, and we sometimes can detect things. Now, here's the deal. With a VSD, you may not necessarily detect it because the saturations are going to be normal. All the blood that's being injected from the LV that's going to go to the pulmonary arteries is going to go back and pick up more oxygen. So in theory, this blood is actually going to be extra oxygenated. And so you may not actually have an issue with the saturation. You may not hear or may not see this on that screen. The other kind of issue with this is that the pulmonary arteries actually change a little bit from birth to later in life. And so sometimes what can happen is that babies are born with a higher pulmonary vascular resistance. And so they may not have as much flow going across the VSD, and you may not actually hear the murmur. As they grow, the pulmonary vascular resistance tends to drop. And as it drops, more blood shunts into the PAs, and that actually can lead to more flow, and therefore the murmur can become louder. So that's how it can get missed sometimes. All right, and then what medications do you use? We usually go with diuretics with a goal of if the left ventricle is way overloaded with volume, sometimes diuretics can help reduce some of the extra volume. And then we also can use blood pressure medications. So a lower blood pressure is sometimes helpful because if we reduce the amount of work that the ventricle has to do to eject blood into the body, then hopefully it'll send less blood to the lungs and more to the body and reduce the amount of shunting. So that's why we sometimes use blood pressure medications. We commonly use ACE inhibitors, which is a type of blood pressure medication. And then lastly, I have seen a medication called digoxin, which is a oral medication that helps the heart squeeze better. And there's a lot of controversy for if it's actually helpful or not because we don't have good evidence to back that up. But there are a lot of cardiologists who feel that they have seen good results with it, and others who feel that it doesn't make much of a difference. But it is another medication that we might try in these kids. But again, if you're getting to the point where you're needing 2 or 3 medications, then you're probably already talking to the pediatric heart surgeon about fixing the VSD because it's causing problems. All right, so I'm going to fly past the story here just because we are kind of coming up to the hour mark. But here's a baby with a hypoplastic left heart who had a complex surgery done. So this is the first step in repairing hypoplastic left heart. They're coming in for a routine visit. Here's that baby. Again, another cute child. Let's go ahead and take a listen to this murmur. All right, same deal. I want people to describe what they're hearing in the chat, and we'll talk about it. This one's a little trickier. All right, so slow, dragging. Harsh and heavy. S2 is harsh. Great. I want someone to type in the chat, is this a systolic or diastolic murmur? All right, great. I'm seeing diastolic. Yes, this is a diastolic murmur. If you listen closely, and then again, like I said, this is tricky. If you listen closely, you'll hear the first sound, a normal S1, and then you hear S2. I think I heard someone say S2 is kind of dragging or harsh. I think I saw that somewhere. And that's exactly what's going on here. So we have a diastolic murmur that's attached to S2. And actually, I think it's helpful, again, to look at this picture. So this is from, I found this from the Stanford website. Normal S1, nice crisp S1 sound. And then here's S2 that has this kind of like dragging sound that follows after it, right? And so this is during diastole, because remember, between S1 and S2 is systole, and after S2 is diastole. So this is a diastolic murmur. We also, to be a little more precise, we'll call this a diastolic decrescendo murmur. So again, the idea that, you know, a crescendo is louder, decrescendo is softer. So it kind of decrescendo as it kind of tapers off. All right. Any guesses on what can cause this? All right, so this is happening during diastole. Oh, hold on, here you go. So left side can't pump oxygen-rich blood, so it bypasses it via PDA and PFO. When those close, oxygen blood can't get to the body. So I think what I'm seeing here is that you have some sort of issue ejecting from the LV, and so you're kind of relying on a duct and a PFO. I think those are interesting concepts. I don't know if a diastolic murmur fits with that. I guess if you do have decreased cardiac output, then you might have, like, let's say you have an atrial septal defect or PFO, you might have increased shunting across the atrium from left to right in that scenario. But I'm not sure if I don't think that precisely hits what we're looking at here. The next comment I'm seeing here is inefficient closing. So I think we're getting onto something there, right? Pulmonary valves aren't closing, great. And someone said not opening properly. So again, let's remind ourselves, what is happening at the second heart sound? Normally, your aortic and pulmonary valves are closed. And so that's at the end of the ejection, the valve should close. And what can happen is if it's not closing all the way, it actually can leak a little bit and you can have a little bit of backward flow. And so someone mentioned pulmonary valve. If you had to guess, between the pulmonary valve and the aortic valve, right, those are the two main valves that are closing for S2, which one do you think is more likely to create a loud sound? Right, so the aortic valve, exactly. So the aortic valve is going to have a larger pressure difference between the aorta and the left ventricle compared to the pressure difference between the pulmonary artery and the right ventricle. So again, remember that your LV is ejecting at a super high pressure because it has to get blood out to the whole body, whereas the RV is only really going to eject to the lungs, and so the pressure in the pulmonary arteries is a little bit lower, as opposed to your aortic pressure is higher, and so the sort of difference in pressure becomes bigger. Your delta is larger, and that creates a louder sound. And so when you hear a murmur like this, you get concerned that there's aortic regurgitation. Very good. All right, flip back to optimize for video here. Okay, so again, I've pulled up some echo images of aortic regurgitation. Sorry, everyone, my computer just froze. Just give it a second here. Okay. So that's not working, so we'll go ahead and just continue on. go. There it goes. Okay, we'll go and skip these videos again, unfortunately, due to technical issues. All right, so again, here's the concept of aortic regurgitation. So blood gets ejected out the left ventricle into the aorta, and because the valve isn't closed all the way, you can get some blood that comes back, and that's that diastolic sound that we hear. So aortic regurgitation, this can be pretty problematic over time. It can lead to overload of the left ventricle. These often need surgical replacement. You know, in kids, we have a few options. We either can repair the valve, replace it, or some other fancy tricks, something called a Ross procedure, which is, again, a little more complex, but some sort of surgical intervention. In adults, a common thing that's done actually is a catheter-based approach. So instead of going to the OR, is just go to the cath lab and to do a aortic valve replacement there. You'll hear the word TAVR thrown around. Again, that's an adult thing. I'm not very familiar with it, but I thought I'd just mention it. Okay, so in the interest of time, I'm just going to jump to the murmur on this one. So here's a 4-year-old, sorry, coming into your clinic. Pediatrician heard a murmur. Alrighty, so this murmur, again, in the interest of time, just because I don't want to keep people here too long. This murmur, I'm not sure if you can hear based off the audio quality, but it has more of a kind of softer sound to it, not as harsh, a little bit more musical. So this is more of a benign murmur. So this is actually called a Stills murmur. So Stills murmur are normal sounds. And again, the thought here is that as your pulmonary valve is open, the leaflets kind of vibrate a little bit as the blood is coming out, and that might cause some reverberation. And that is one theory for that sound. These tend to be louder when our kids are laying flat. So supine just means you're laying on your back. And again, has this kind of musical quality. I'm not going to lie, when I first heard that as a medical student, I was like, what the heck are you talking about? This does not sound musical at all. It took me a long time to kind of understand what people are trying to say. And I think, like I said, wherever you end up, for any of you, try to build that mental library in your head of what these sounds are. Because once you start to know what different sounds are, you can kind of compare and contrast and get an idea of what one thing sounds like versus the other. So, all right, that's actually it for the actual presentation today. Let me just catch up on some of the questions here. Someone asked, is it possible that someone can hear their own murmur, or can you only feel them? So I've had people, at least in the adults that I've seen, who have really loud murmurs, so people who have like grade 5 or 6. When they have murmurs that are that loud, sometimes they can actually hear the murmur themselves, like when they're laying down, like at night when it's quiet and there's not that much noise. They tell me that they can actually hear the murmur, so that definitely is possible. Some adults who have mechanical valves, especially aortic valves, because they close with so much force, they sometimes can hear their own murmur as well. So, all right, sorry that we ran a little overtime here. Was asked to give a little bit of advice just to future physicians here. This is something that I was told during my training, and I think it's really helpful advice. And so when I say play your own game, I think what that means is like everyone comes from different walks of life. Everyone has different backgrounds. When you're going to start comparing yourself to others, it becomes really toxic and not helpful. I think it's easy to go online. You go to like Student Doctor Network and you read people's stories and you're like, everyone around me is doing 10 extracurriculars and research and I'm here not doing that. Like it kind of starts to lead to feelings of, that you're not good enough. And so I think overall, it's just not a helpful way to approach things. So someone gave me this advice of just play your own game, meaning just do what you got to do. You do you. You know what you need to accomplish, and don't let other people kind of, don't be comparing yourself to others throughout the process, because there's going to be plenty of opportunities throughout your career to do that, and I think it's important to remember that you're just doing what works for you. All right, so that's all I have for today. Again, my contact information is down there at the bottom. I'm happy to speak to anyone about questions, whether it's about application process, residency, medical school, fellowship, whatever it may be. I'm also on Instagram as well, and I do respond to those a little more quickly than email as well. So feel free to reach out. Thank you all so much for attending. I had a good time with this. Oh, let's see. Here's another question. So before we wrap up, one question. What does it mean when a child is diagnosed with a hole in a heart? Yeah, so that's a good question. So again, when you say hole in a heart, kind of colloquial term for saying that usually one of the septums has a defect in it. So when people say that, it usually means there's a defect in the ventricle or in the atrial septum. So we say VSD or ASD is usually what that means. So it's a good question.
Thank you so much, Dr. Masood, for such a wonderful presentation. Everyone learned so much, and the case presentations were super interesting. And we really appreciate you answering all of our questions. So thank you so much for taking the time to do this today. We really appreciate it. And for everyone still watching, the Google form for this session has been posted in the chat box, and it will be posted in the description of this video shortly, so keep an eye out for that. And just one quick announcement before we end. This coming Friday will be the start of our February roundups. So every Google form for the month of February will be reopened at 11:59 p.m. Eastern, February 26th, and close at 11:59 p.m. Eastern on February 28th. During this window, you can watch any past sessions from the month of February and fill out the forms to receive credit. For news and updates, please check out our Instagram @WebShadowers. And once again, make sure you fill out your attendance form in the next 30 minutes. And thank you so much again, Dr. Masood. We really appreciate it.
Sophia, can I take the quiz too, or is that cheating?
Sorry?
So can I take the quiz too, or is that cheating?
Oh, you can definitely take it if you want. I expect 100% though. I hope you have a great rest